First of all, thank you very much for the opportunity. It is always a pleasure to interact with my colleagues in neurology. I'll be a quick because I know it's almost evening and you guys are listening to so many presentations since morning. So I'm going to talk about this role of early stroke rehabilitation in low resource settings, specifically Pakistan. So my talk is going to revolve around four main themes. That is, number one, I'll start with presenting evidence for rehabilitation in stroke units. Then what are the basic principles of acute stroke rehabilitation that all of us can integrate in our clinical practice? Then what are the basic steps involved in acute stroke rehabilitation, which do not require a lot of investment, money, or use of a lot of gadgetry, and which can actually improve the quality of life in these patients and reduce disabilities. And in the last, I'm going to end with a summary and a take-home message. This presentation very well fits into the larger theme of this conference, that is bridging for better stroke care in Pakistan. Because we all need to understand that stroke care does include a large component is acute neurological care, which would reduce the mortality. But at the same time, we also need to reduce the morbidity and long-term disabilities. And here where rehabilitation comes in. So I'll first of all start with presenting evidence for stroke rehabilitation. A little bit of disclaimer. Unfortunately, like in most of the medical sciences, most of the evidence for effectiveness of stroke rehabilitation comes from the West and technologically advanced countries like Northern America, Canada, Europe, Australia, and Japan. But we can extrapolate these results to our local Pakistani population as well. So, for example, it is clearly mentioned in the literature based on the large amount of evidence in the last 25 years that interdisciplinary combined acute and rehabilitation stroke unit, they reduce death, that is mortality. They reduce dependency, that is long-term disability. They reduce the need for institutionalization and length of stay of the patient in the hospital, which is very important in a context of a developing country which does not have a large number of beds to cater for the needs of all patients. At the same time, a dedicated stroke rehabilitation units, which are attached with the acute neurology ward and which admit patient either directly from the medical ward or a neurological facility following acute stroke care. These kind of units, they help improve functional outcome as compared to the standard care that is usually given to these patients in most of the developing countries. In stroke units, which integrate a comprehensive acute neurological care along with a coordinated post-stroke rehabilitation, the patients who are managed in these stroke units have a better outcome at 3 months, 6 months, and at 24 months of follow-up. In addition, acute stroke patients have both needs. They need acute neurological care and they also need acute rehabilitation intervention. Those units which provide a coordinated acute care along with a post-stroke rehabilitation have better outcomes in terms of long-term survival of the patient, community reintegration, and reduced number of disabilities. And the good thing is that management in a stroke rehabilitation unit would confer survival benefit, which would remain with the patient more than 10 years post-stroke. So these are the things that should actually make us pause for a moment and make us realize that there is a value of integrating stroke rehabilitation interventions in the acute phase as well, because they are going to lead to reduced morbidity, reduced complication, and increased integration of the patient back into the life as a useful earning member of the society. UK has recently started establishing hyperacute stroke units, the HASUS. And apart from other things that they offer, like rapid special assessment and diagnosis by a neurologist, hyperacute treatment in form of thrombolysis, and physiological and neurological monitoring by a trained team, they are also offering early and acute rehabilitation services to these patients who are being admitted in hyperacute stroke units. And the trials are still going on, and maybe they'll be out in a couple of months to years. But hopefully these trials will also show that there is a role for providing rehabilitation services even in the hyperacute phase. Coming to the next part, that what are the basic principles of stroke rehabilitation that we should consider? First of all, yes, a comprehensive stroke rehabilitation will take time, cost, money, and a coordinated team. That's true. But we need to understand that we are working in Pakistan. We have to consider the ground realities that me and you are facing on a daily basis. We do not have a lot of resources. And still we can integrate some of the principles of stroke rehabilitation. And what I always say, simple things matter most. And I'm going to show you the pictorials. Then stroke rehabilitation is not nursing care. Please remember that. So if unfortunately your stroke patient is like a gone case, he's in a deep coma and there's no chances of like recovering, probably that patient is not a candidate for acute or integrative rehabilitation. These kind of patients might benefit more from long-term nursing care. So that's why it's important that in the acute phase, you might want to involve your rehabilitation medicine physician who can come and guide you which are the best candidate for active early acute rehabilitation. And then medical stability is mandatory. So if the patient is, let's say, having hyperglycemia, diabetic ketoacidosis, the blood pressure is fluctuating very rapidly, probably it's better that you focus on the acute medical issues first, make the patient stable, and then transfer or ask for rehab interventions. And last but not the least is that each patient of stroke is going to be a different patient based on their disability, age, morbidity, financial, and social status. And that's why disability assessment by a rehabilitation team right at the start is very important in order to clearly set the goals for long-term, subacute, and acute rehabilitation interventions. Now, coming to what are the acute phase rehabilitation interventions that each one of us, whether we are a rehab physician, rehab professional, a neurologist, or maybe an internal medical specialist who's working in a far off away place and who has to provide services to rehab to acute stroke patient. So what can they do which can reduce the incidence of complication and reduce the disability? So these are very simple interventions that can make a lot of difference in the patient's life. And these include, number one, correct positioning while lying and in the wheelchair. Number two, early initiation of physical therapy or what you call physiotherapy and mobilization. Then prevention of aspiration, which can lead to mortality. And then appropriate bladder and bowel management. So, acute rehab intervention usually 5 things. And since we know that a rehab team is actually a teamwork, which includes a rehab medical specialist known as a physiatrist, then we have like rehabilitation nurses, we have physical therapists, occupational therapists, a clinical psychologist, and in many cases, a prosthetist as well, who would fabricate the splints for the patient. So that's why, first of all, we assess the patient and we see what is the disability level of the patient. So sometimes the patient might be having more motor disability than cognitive disability. Sometimes he or she might be having more cognitive issues and speech issues and maybe dysphagia as compared to motor issues. So depending on the patient's condition, we decide which team member has a larger role to play. All of us are going to play their roles, but one of us is going to play a larger role than others. So let's start with the positioning. Pretty simple things. So the patient is hemiplegic. So the leg is externally rotated. If you keep this leg in this position after a couple of days to weeks, when the patient will be discharged or will go back home, he would have developed external hip rotator contracture. Lead to a bad posture. And in many cases, a contracture at the knee and ankle, which will not allow the patient. If you go by the book would say and use the word trochanter roll. I haven't seen a proper trochanter roll in the last 15 years. So what would you do in Pakistan or developing country? You try to be ingenious. So you start using the local things available. So every patient in Pakistan comes to the hospital with 2 or 3 towels. So you take a fresh new towel, at least 12 inches length, and you simply roll the towel. And if the towel is not available, you simply ask your ward nurse to please give you 2 cray bandages 6 inches long. That would make 12 inches. You make the patient leg in a neutral position and you put that trochanter roll under the greater trochanter. And the result is a leg which is in a normal position. And hopefully it would remain in that normal position if you keep it there. And once the patient is in the spontaneous recovery mode after the rehabilitation and physio, hopefully the patient is going to walk much better. Foot drop can be because of spasticity, and in the acute phase can be because of weakness. And long-term foot drop would lead to TA contracture, again, which would hamper the long-term mobility of the patient. So a simple intervention in the acute phase can lead to long-term gains for the patient. And that could be the use of footboard. Nobody has seen a footboard, at least in Pakistan. It is available in very few places. It is not available in most of the urban areas. So what would you do? You simply take a pillow, you position the patient, you bring him or her down, and you place the ankles in 90-degree neutral position. Now look at the lower limb. It is not externally rotated. It is not in the equinus position, which means in the long term, it's not going to develop the contracture, which would have been there if there was no intervention in a form of a trochanter roll and a simple pillow board. This is the position you should adopt ideally while the patient is in the supine position. Why? Because patients with stroke are at high risk of developing adhesive capsulitis, shoulder subluxation, hemiplegic shoulder pain, and in some cases, even supraspinatus tears. So simple positioning like these can prevent all those complications. And obviously, in acute stroke patient, because they are immobile, they are at high risk of pressure ulcer, you have to change the position every 2 to 3 hours. So whenever you change a position in lateral, right lateral or left lateral, so this is the positioning or the use of appropriate use of pillows that would actually help you maintain the posture in the correct form and would help the patient in the long term. If shoulder subluxation is a very important and neglected cause of long-term shoulder dysfunction and pain in stroke patients, unfortunately for most of us, at least during ward rounds, we do not expose the shoulder of the patient and check for shoulder subluxation, which can actually be detected by a simple clinical examination by using your sulcus sign. You don't need to go for like an MRI or an X-ray scan. And it has been reported that it ranges from 30% to 84% depending on where it has been reported from. And it can lead to like very severe form of adhesive capsulitis, disability, reduced movement at the shoulder, and pain. The book again says use a shoulder lap or a shoulder strap. Again, the shoulder lap, the wheelchair lap tray is not available in Pakistan, and the shoulder strap is not freely available in smaller cities where people still have stroke. So what would you do? So using these simple intervention like use of a pillow, which pushes the head of the humerus. So coming to this bladder management, the issue is, usually what happens that we don't have integrated care. So once the indwelling catheter is placed, people somehow forget to take off that catheter. And I have seen patients who come to me 3 months post-stroke and they still have catheter in place. Nobody has bothered to take out that catheter. If you have a great rehab team and a good coordination with the neurology team, please try to avoid indwelling catheter and use alternative like clean intermittent catheterization if possible. Why? Because we need to understand that bladder dysfunction in stroke is transient as compared to bladder dysfunction in spinal cord injury, which is permanent. So in most of the cases of stroke, the bladder function would be regained within a couple of days. So it is important that you remove the indwelling catheter as the earliest, as soon as possible, and give a trial of spontaneous voiding to that patient. And believe you me, most of these patients are going to spontaneously void, number one. Number two, in the acute phase, usually there's not much role of pharmacotherapy like tolterodine and anticholinergics. So probably if you even start with like a proper intake output charting and you keep the intake and output of the patient monitored, in most of the cases, patient is going to regain the continence. Dysphagia and aspiration pneumonia are major concerns because up to 40% of the patient with stroke can have silent aspiration, which can lead to morbidity and pneumonias. And bedside assessment is absolutely important. And again, if there's a video fluoroscope available, that's fantastic. But that's not available in most of the cities of Pakistan. So what do? Please try to involve the speech and language therapist or pathologist from the rehab team. These are the people who are trained to do assessment at the bedside, both for dysphagia and communication disorders. And while you put in a nasogastric tube, which is very important, at least in acute stroke patients who cannot take in the diet and can't eat, you need to be aware of the reflux, and you have to position the patient accordingly at 45 to 50 degrees, because even with an NG tube in place, patient can develop aspiration pneumonia. And whenever you order an NG tube placement, please make sure that at least in the first 24 hours, the patient is supervised while the feeding schedule is followed. And the patient and the attendant should not be left unsupervised that they do whatever they want to do. And that's why a healthcare professional in form of a nurse, a physician, an assistant, or occupational therapist should be present there while NG tube feeding is being done. Apart from that, if you want to reduce the risk of aspiration, there are very simple compensatory techniques that can reduce the risk of aspiration up to 25 to 35%. For example, if the patient is stable and he has regained the ability to sit, you might want to sit the patient upright in a chair with the head tilted forward. It would reduce the risk of aspiration. Please modify the consistency of food to pureed solid and thickened liquids. Or please in Pakistan, अपने मरीजों को clearly बताइए कि what do you mean by these English terms, pureed solid and thickened liquids. So you might want to say जी कि दलिया खिलाइए, सागूदाना खिलाइए, custard खिलाइए, या डबरोटी उसको कर मैं दूध में डबोकर खिलाइए. Please be very clear about the communication that you do with the patient. Many a time हमारी हाई-फाई अंग्रेजी और टर्मिनोलॉजीज मरीज को समझ नहीं आती, and they can actually lead to disasters. And then, for example, very simple thing. What is a small bolus of food? Most of our patients are not clear about this bolus of food. So you might want to clearly tell them कि जो होता है खाने का चमचा, that is a large bolus of food. और जो चाय की चमची है, that's a small bolus of food. And whenever you start feeding your patient, always start with a half teaspoon. उस चाय की चमची का भी आधा दीजिए. Please remember, simple things matter most and can actually save the life of a patient who can develop aspiration pneumonia. And last but not the least, a simple thing. If the patient is having right hemiplegia with facial paralysis, try to direct the food away from the weak side. Why? अगर आप उसको बार बार weak side पे रखेंगे, he or she cannot chew, उसका bolus बड़ा होता चला जाएगा, and the patient might choke on that food bolus. It can lead to disasters. So simple things matter most. So the summary of my presentation is that stroke rehabilitation is an essential and integral part of a comprehensive stroke unit. So again, my very respected colleagues are sitting here. So most of you already have great stroke units available. So please try to integrate a comprehensive stroke rehabilitation team along with other caregiver members as well. Stroke rehabilitation is a continuum of care. It is not an optional activity. It is not something that you write at the end of discharge. Stroke rehabilitation planning should start along with the acute planning at the time of admission. And please remember, not as a disrespect, but just as a way of increasing awareness, that physiotherapy exercises are only part of the complete stroke rehabilitation protocol. You have to consider the holistic team approach and a multidisciplinary team involving the physiatrist, rehab person, the neurologist, the OT, PT, SLP, under a care of a physiatrist can deliver better results, leading to better outcomes. So the call for action for all of you is, number one, please try to integrate stroke rehabilitation services in your stroke units wherever possible, and try to employ a multidisciplinary team involving a rehab medicine physician or physiatrist instead of only giving referrals for physiotherapy and exercises. It's important for rehabilitation professionals that we should actually collect data and generate local evidence on the effectiveness of different rehabilitation interventions that we provide to the patient on a daily basis. And one way could be that there are a lot of good international guidelines available on the effectiveness of stroke. We might want to download those guidelines, and after permission, we can adapt those guidelines as per our local needs, as has been done by the PSN. And last but not the least, we have a lot of success stories to share. And probably it's time that at these forums, we should be sharing all these success stories so that people get motivated and they can also refer patient for a comprehensive, coordinated, multidisciplinary stroke rehabilitation. I thank you all for your patient listening. It's always a pleasure to be part of this forum. Thank you very much.